Yeah, hi everybody. This is the effectively it's going to be a review session for a review recording rather for exam 2 in anatomy and physiology. I'll probably have to do it in two parts just because of time. I'll start with the cardiology aspect of it. And so there's going to be some anatomy because typically you have to, that's really part of its understanding. You have to know about the layers of the heart, of which there are three. Okay, remember it's endocardium, which is just basically the lining on the outside, pericardium, the lining on a big part, endocardium, the lining on the inside, along the valves, etc., chambers. Pericardium, effectively the lining on the outside, same, both simple squamous epithelia, and remember, as well as being pericardium, it's also effectively pardon me, the visceral pericardium as opposed to the parietal pericardium. So there's a distinction that's there. It's important. And by far and away the thickest area, or the most dominant area, is the myocardium. That's really what makes it shake. Particularly on the exterior, is less. The interior is important. What valve? I mean, you do the anatomy in lab with Dr. Robbins, but the reality is know what vessels flow where. Okay, where the superior and inferior vena cava flow into. Is the coronary sinus also flowing into that same area? We know it's the right atrium. Where the pulmonary veins come in? How many pulmonary veins are there as compared to arteries? Remember, I talked about vena comitantes. Basically for every artery, there's two veins. So there's four pulmonary veins because after the trunk, there's a right and left pulmonary artery. That's the kind of stuff that you need to be familiar with. We need to be familiar a bit with the coronary arteries. They lay in those septa, whether it's that atrioventricular septa or whether it's the interventricular septa, either anterior or posterior. Remember, so the coronary arteries are given off first. They go off directly after the aortic valve, almost immediately. So there's a number of illustrations that you can look at both online and in that, I believe in that Welsh Hole textbook. And so the heart feeds itself first, as I'm fond of saying. So coming off the left, you have the anterior interventricular artery. We used to call the left anterior descending. You have the circumflex artery, and the circumflex goes all the way around to the back. We see a lot of circumflexes when we get into vascular anatomy, particularly in the extremities as well. And on the right, we have the right coronary artery. It gives off the marginal that goes along that sort of, if you're looking at the heart, the left-sided margin, so to speak. And the right continues to really form the posterior interventricular artery. And again, all the designated septa is where they are found, typically. And remember the coronary sinus on the back of the heart, that's where the cardiac veins flow into. You have coronary arteries and cardiac veins. All of that is very, very relevant to this. So understand which valve is where. Aortic and pulmonary are self-explanatory. They exit the respective ventricles, aortic on the left, pulmonic or pulmonary on the right, and go to the rest of the body or to the lungs, depending on which one it is. There's semilunar valves with three cusps. And then you have the tricuspid and bicuspid, respectively, between the right and left atrio and ventricular areas. Okay, so the right atrium is the tricuspid, the bicuspid or mitral on the other side. So those names are all useful. Remember the distinctive aspect of the pulmonary artery and the pulmonary vein. Again, arteries go away from the heart, veins bring blood to the heart. Therefore, pulmonary artery is the only artery that has venous blood, if you will, deoxygenated blood. And the pulmonary vein is the only vein that has arterial blood because it's coming back from being oxygenated in the lung, with the exception of the umbilical circulation. So for our purposes, we're referring to the adult. So I suggest, you remember that. So all of that's part of what we look at anatomically. We know there's a certain amount of insulation around the heart. There's a little bit of fat around the heart. That's the same for everybody. If you're overweight, it's not like your heart's carrying a ton of weight. Outside of you, if you're very skinny and you have a BMI that's it's under 5, it doesn't mean there is proportionally a little less. But let's be clear, It's not going to vary. Same is true for your kidneys. So your organs inherently have a certain amount of fat that's sort of an exterior to the capsule or the outer thing that's about it. So understand that that's typically a all around a typical heart, barring some heart that really has some severe injury or genetic defect. Okay, so I think all of that's important. You need to know where the different parts of the conducting system are. The SA node, which is in the right atria, generally in the posterior wall. The AV node, which is in the intraatrial septa, and along that sort of, which we call it's really the septa, both the interatrial and continuing into the interventricular septa, is that atrioventricular bundle known as the bundle of His, capital HIS, then bundle branches, and finally they go on either side, down either side of that interventricular divide, and then the Purkinje fibers, or that subendocardial conducting network, basically goes all over the sort of exterior for the ventricles. I think that's important. You have to understand mechanically that because the left ventricle is so much more muscular, there's a lot more pressure generated, and that's because it's a high pressure system effectively. On the left side, it's got to go all the way around your body and make its way back, as well as up to your brain, okay, typically against gravity, versus the idea of having a very slow flow to go through all the lungs. Too much pressure in the lungs, there's so many capillaries, you're going to get fluid in the lungs. So mechanically, this is a slow journey through the lungs, and it's advantageous, particularly people who have lung disease or their hearts are not functioning quite as well, because it doesn't take very long when we get to respiratory for the blood to get oxygenated. So it allows extra time, so to speak, for people when they have limitations with regard to their respiratory physiology. And when someone has a heart attack, it's called an infarction. It's specific to the myocardium. So a myocardial infarction means heart muscle has died from lack of oxygen. It doesn't mean there's necessarily a clot. It can be a relative supply and demand thing. Okay, so you don't have to necessarily have a clot, but if the heart's doing too much activity and the blood vessels are too narrow and you're not getting enough oxygen in that particular area, myocardial cells die. Period. That's what infarction is. Infarction is death of tissue from lack of oxygen. We just locate the area where this infarction occurs. It could be in the kidney. There's different areas that get infarcted. And it's a big distinction between infarctions and infections, which are, as you know, microbial in origin. Know about the EKG. I always say EKG, it's fine. They're the same as ECG. There's no difference. The P wave. Remember, that's remember, it's an electrical event. Atrial depolarization, the QRS, ventricular depolarization, and because of its size, it obscures atrial repolarization, which happens around the same time. And the T wave is ventricular depolarization. So all of those are important events that you have to be familiar with. And remember, we talked a lot about that with regard to what happens when there's irregularities. The SA node is supposed to be the weakest sodium channels and sets the pace. That's why we call it the pacemaker. But if it fails for whatever reason, if there's been a heart attack, damage of some type, injury, whatever the situation is, if that fails, then the AV node can take over, but it only generates about 40 to 50 beats per minute. That's really insufficient to sustain any degree of activity. It's probably sufficient to sustain life, but it would be very difficult. And again, the go-to treatment nowadays, when we have those kinds of variations of heart block, that would be identical to a total heart block, where only the ventricles are limited but still able to be because of that node. That's when pacemaker implantation is part of it. And remember, the only electrical connection is that AV bundle between the atria and the ventricles, and therefore you have to put electrodes into both the atrium and the ventricles, and effectively the pacemaker acts as a connector as well. That's setting a pace for this. With regard to our controls, we want to govern the heart. The heart normally would be excessively active, like a lot of our body systems. And so therefore, we look at the system that limits its activity rather than the one that accelerates it. We learned about this in autonomic nervous system, in AP1. The whole idea is that this is that one interesting one where the vagus nerve with acetylcholine is normally something that causes things to be excitatory, and here it inhibits. It slows down the heart rate. That's the dominant thing that governs our heart. If it doesn't, we are in big trouble. No two ways about it. Heart murmurs are really related mostly to valvular abnormalities. They're not as common as you think, but they certainly occur. But most of the time, may be born with valvular abnormalities, and those create the murmurs, whether it's stenotic, whether it's prolapsed, whatever. And a lot of times the underlying factor, and we get to this in micro, I do, right, is underlying history of streptococcal disease called rheumatic fever. Until we had antibiotics, this was much more common than you think. We talked a lot about cardiac output. Remember the relationship between heart rate and stroke volume, how that has to be. It's so important. When we get to respiratory, we're going to effectively, that has to mirror or be identical to what we call the minute volume, which is the same thing. How much blood we're moving out of the heart. We look at the volume of blood that is ejected from at any one time from a ventricle, be it on the right side or the left side, times the number of beats. And we're going to have to marry that to the amount of oxygen, because that's what the amount that's going to the lung to be reoxygenated. So heart rate and stroke volume, they're the biggest factors that are there. Remember, certain things that have chronotropic and inotropic things. The inotropic impact, rather, we call it positive and negative. For instance, negative chronotropic is what happens with acetylcholine by way of the vagus nerve and the parasympathetic. They have no real impact on the force of contraction, whereas epinephrine in fight or flight is positive chronotropic, increases the heart rate, and positive inotropic, it increases the force of contraction. So there was a whole section on that, and please review it. If you're wondering, I have those two Marie PowerPoint 17A and 17B on both of the blackboards. If you have any trouble accessing, just send me an email. We'll figure it out. Again, anatomically, the atria are so small, but they have auricles, named because they look like little ears, which are sort of like extra chambers that, almost like if there's an overflow volume, they basically increase the potential volume of a relatively small atria. Okay, so you need to be aware of that. So I guess the best way to describe them are kind of like entry chambers that are used when maybe there's too much blood in there. I think maybe that's the best way to describe it. And remember, we all think a heart is very efficient, but efficiency is defined by whatever system it is in. It's like way back, you remember we talked about ATP and efficiency. I mean, basically, of the carbohydrates we ingest, 40% of them go to ATP. The rest we lose is heat. That might sound like a bad system, but not for our body. The same thing is true about the heart. They eject the majority of the blood. Remember, we talked about it. When the ventricles fill, there's about 120 milliliters or 4 ounces. The ejection fraction is 57%, roughly 70 milliliters are ejected and 50 milliliters are left. So that may not seem like a great deal of efficiency, but for our heart, it's perfect. So understand it depends on the system with all of those things. And what we do when there's problems with the heart, whether we're just trying to get back into condition, whether there's been some time of what we call heart event, whether it's truly a heart attack or just areas of insufficiency, aerobics and cardiac rehab, the result of them is to develop collateral circulation. Remember, I'll show you that thing with all the coronary arteries. There's all those anastomoses. As we utilize the heart scientifically in a rehabilitative or aerobic sense, we develop more of those pathways, and they can bypass areas of either that are blocked, have been damaged, or are potentially blocked. And so what we can do because of that, we can effectively decrease our resting heart rate. That's the goal, because typically people who have had heart damage like that, their resting heart rate is going up, assuming that they haven't damaged the SA node in the process. So, I mean, that's all part of it. I've covered a lot of it. Yeah, things that we look for. They extended on the electrocardiogram. If we have a wider or basically taking more time PR interval. So if the P wave is extended from that roughly 3 squares to 5 squares, then we have a certain amount of heart block. So we're looking at a failure of the signal to efficiently get from the atria to the ventricles. Normally, remember I said it's from about 1/10 to 1/5 of a second. That's 0.10 to roughly 0.20 seconds. And really, that's the rate determining step, because that's the whole goal, is for the atria to effectively maximally fill the ventricles every time for the most efficient kind of pumping that's there. When we look at irregularity in T waves, whether they're elevated or depressed, or for some reason unusually elongated or misshapen, we're thinking about ventricular damage. And don't forget the heart sounds. Remember the first heart sound? There's the mitral and bicuspid, the atrioventricular valves closing, and the semilunar valves closing is the second heart sound. And I think all of those are important. I have a few more questions, and I'm going to, in the interest of time that I have, call an end to this, and I'll do the blood part secondly. So I just want to make sure with all those things. Oh, resting heart rate again, desirable. If you look at all the authors, 60 to 80. And resting is truly resting, like you're sitting, you're studying, or you're watching TV, you're reading a book. Just you're perfectly calm. Test that. Just check your own pulse. It's so easy to do. And if you're in that golden 60 to 80, you're doing fine. If you're an athlete, maybe it could be a little lower, but typically 60 to 80 is the goal for the typical average healthy individual. I think that's important to remember. And possible heart attack signs and symptoms. So possible heart attack would be, how should I say it? Typically, classically, there's chest pain is associated with it. There's pain that goes down the arm, okay? Particularly on the medial aspect of the arm, down the left arm. So that's the classic area. Remember, we looked a little bit at referred pain in ANP1, and this is a classic example, but it doesn't limit to that. Heart attack is so severe that it can manifest itself as indigestion, abdominal pain, difficulty in breathing, tightness in the jaw, okay, difficulty in swallowing. All of those are part of it. So remember that. And again, lastly, remember the dicrotic notch. That is not something that we see on an electrocardiogram. That is a pressure. And it has to do with the second heart sound being created by the rebound phenomena. I went into it in length in both of our sections about how those are elastic arteries, and we're going to revisit that again when we do blood vessel physiology, how they're stretched and how they rebound as the ventriculars begin to relax or go into diastole, and it goes and the flow, that rebound phenomenon not only helps push the blood and make sure it's less pulsatile and create more of an extended, sustained, relatively high flow, but it also slams those doors shut and rebounds off it and creates this secondary pressure wave. We call that the dicrotic notch. And I'm going to stop there. I know this is relatively brief, but the next unit is the blood. It's going to take me a little bit longer, and I'm trying to do this in the morning before I have to go to my morning classes. So thank you very much. And I'll have more for you later. Bye.